All right, looks like we're going to get started. Hello, everyone. Welcome to the American Indian and Alaska Native Prevention Webinar Series. My name is Cindy Sego, and I'm the Program Coordinator for the Center. And today we have Dr. Paul Gilbert presenting on Developing Community Tobacco Prevention Activities, a Guiding Framework and Resources.
Thank you, Cindy. Oh, I'm
So,
sorry.
just before we start the, the presentation proper with Dr. Gilbert, just to go through the introduction slides to let you know more about our center and the work that we do, and also to let you know that this webinar is being recorded, so it will be accessible to everyone who is on the webinar and even those who are not able to get to the end. So this training series is brought to you by the National American Indian and Alaska Native Prevention Technology Transfer Center. We are part of the PTTC network, which also includes 10 regional centers, the Network Coordinating Office, and the National Hispanic and Latino PTTC. In the next couple of days, we'll send out an email to everyone who attended, and this will include a link to the recording, handouts of the slides, and the CEU request form. Our center is NADAC certified educational provider, and we will be happy to provide you with the CEUs for a $15 fee. So immediately following today's webinar, you'll be redirected to our GPRA evaluation. This survey will take just a few minutes to complete, and it asks you about the satisfaction with the event. And this feedback is very critical to the work that we do, and we value your opinion, and we really appreciate your time in sharing your thoughts with us. And going on, so that everyone knows, you'll be muted during the webinar. So you could please use the chat box to share your questions and your comments, and we'll address them at the appropriate times during the presentation. So more on Dr. Gilbert. Our presenter, Dr. Gilbert, is an assistant professor at the University of Iowa College of Public Health. He is at the Department of Community and Behavioral Health and is a faculty member for the Prevention Technology Transfer Center. His research includes trying to understand and address alcohol-related disparities, in particular the ways gender, race, and ethnicity, and also sexual orientation shape drinking patterns and risk of alcohol use disorders, and also its use in treatment services. He's also a prevention specialist, and we are thrilled to have Dr. Gilbert on our team for this project, and would like to welcome him at this time. Thank you, Dr. Gilbert.
Thank you very much, Cindy. Now, let me just make sure that I can get to the slide deck here. Okay, there we go. I think we already covered the introduction there. Cindy's very nice introduction here. I just wanted to say, yes, I am one of the faculty members associated with the Prevention Technology Transfer Center, and I'm very pleased to be speaking with you today as part of this webinar series that the center is running. I want to start by telling you a little bit of the plan for this hour we'll share together. There are three main parts that I want to cover with you all, talking a little bit about why this focus on tobacco use, essentially defining the problem, and then part of the framework that I promised in the title of this talk is actually three distinct ways that we approach prevention work in public health. Some of this you may have heard already, other it may be new, but I want to tie it together as recommendations for a way to approach community responses to tobacco use. And I'm also going to give you some resources, thinking very much that this whole series and the center's point is to share functional solutions to problems. Along the way, I'll be making a handful of recommendations. As I said, I'll end with some resources that I can direct you to. As we go along, if you have any questions, please don't hesitate to ask them. Right now, as Cindy said, everybody is going to be muted, so we'll be watching the chat box to see if uh, if there's any questions or comments that come up or any introductions. I'm also going to allow some time at the end so that we could have a bit of a discussion, or I could answer any questions that folks might have. So the first question here, the first thing to tackle is simply defining the problem. And I wanted to start with this because a lot of times when we talk about tobacco prevention and control, we'll use phrases like tobacco-free or zero tobacco, and that is not appropriate for American Indian communities. And the crux of it here is that we have traditional use of tobacco that is culturally important, that is not the type of use that we are focusing on when we think about tobacco-related harms. And on the screen here, you see some of the aspects or characteristics of this traditional use, that it is ceremonial, not casual, that it is respectful, that it may be used in a medicinal way, and that the ways that it's used, the important contrast to commercial tobacco is that it's often less frequent, less intense, and there's often limited exposure to children, some of the things that we are oftentimes concerned about with prevention control or tobacco prevention. So I do want to really start with this and say that we are not focusing on traditional use of tobacco, rather it's the commercial use. And this is typically the manufactured cigarettes. This is where we know that it is clearly linked to health problems. It's the habitual use, often because of nicotine dependence. There are some special things to think about, or some characteristics that are relevant for American Indian communities when we're talking about commercial use, that in some cases it may be a way for youth to rebel to be using commercial tobacco. Sometimes also there may be some mixed messages that are sent, especially when traditional forms of tobacco are not available and folks use commercially prepared things like packs of cigarettes exchanged, say at a funeral or other ceremonies. It may be giving this mixed message that commercial tobacco is actually acceptable and it is part of the tradition. I want us to make a distinction here that we are only focusing on the commercial tobacco and the ways that it's used in harmful ways, distinct from that traditional and ceremonial use. We also have to acknowledge that there have been attempts to exploit this American Indian tradition with either images or the history of tobacco use in the commercial tobacco field. And this is again muddling the picture, confusing things. But for our purposes today, we are focused on that commercial tobacco use. It's probably not a surprise to folks that this is a primary concern in the United States at large. It's one of the behavioral risk factors that is associated with a number of our leading causes of mortality. It is probably the leading cause of preventable deaths. But we have seen a lot of changes over time. And on the screen here, I put up a graph of the changes in smoking prevalence. And this is, I believe, cigarettes. Yes, current cigarette smokers from 1965 to 2017. We see a steady decline, which is good. That's what we want to see. We also see some differences between males and females. Men tend to smoke more than females, but the prevalence gap has been narrowing over time. It was much bigger in 1965, which a much larger number of men smoking. And that has narrowed as the whole trend has decreased. But when we look at American Indian communities, we see a disturbing trend here, that even though the prevalence has been declining overall over several decades, we see the highest levels of cigarette smoking among American Indians here. This graph on the screen shows any tobacco use plus several different other types of tobacco, but what we're going to be concerned about here is cigarettes, the second set of bars from the left. And it's broken down by racial ethnic group here. And the left-hand side the highest level of smoking is among American Indians, and then it decreases with other racial ethnic groups here as you go from left to right. What this indicates is that this is really a key concern for public health among American Indian communities. And we know, in fact, from health data, from surveillance surveys, from our other public health records, that not only is smoking highest among American Indians compared to other racial ethnic groups, but it's also a leading contributing factor to some of the main health problems among American Indians. Cardiovascular disease, different cancers, diabetes are the three top. So all of this is the justification for today to focus on commercial tobacco and addressing its use in communities. I'm going to move on to the first bit of the framework, the first aspect of it that I wanted to talk about. And this framework is really part of a comprehensive public health approach. And the first thing that I wanted to talk about is just this notion of levels of prevention. In public health, we'll talk a lot about primary, secondary, or tertiary prevention here. And I've put a table on the screen, and I've highlighted the first column on the left, just what these levels are. We separate these out generally by 3 levels. What this means, the intention here, is the middle column on the table. When we talk about primary prevention, what that means is that we're going to prevent the case of disease or the health problem or maybe the death from happening in the first place at all. That is the most fundamental form of prevention, that it just doesn't happen at all. It's the hardest to show that we're effective because, in effect, our success is a non-event. The disease doesn't happen, the death doesn't occur. It's hard to justify things that don't happen, but that is what we're aiming for most fundamentally. But it doesn't mean that that's the only type of prevention that we're working at. If we go down to the next level with secondary prevention, that is really about finding that case of disease, discovering that behavioral problem or that health issue before it could get any worse. A lot of times when we talk about clinical services, we're talking about things like early screening for disease, maybe before symptoms appear, before it might be apparent to somebody, so that we can identify it and treat it and cure it. In public health, this is roughly analogous to clinical medicine, finding those problems earlier. The advantage is that we can oftentimes intervene with less effort, with maybe less burden when it's earlier in the course of a problem developing. But again, that's not the end of it. Sometimes there are problems that have developed, and then we have to address that. And that brings us down to the third level here on the table, the tertiary prevention. And that really recognizes that sometimes diseases happened, there's an outbreak, there's a health problem, we've missed the opportunity for primary or secondary prevention, and this is really about minimizing the damage that comes from that health problem. In the column on the far right, I've listed just some brief examples of what each of these types of prevention might look like related to tobacco use. So in primary prevention, because we want to prevent the harm from happening in the first place, or the problem from developing, or for the case of disease from starting, this might be something like an anti-smoking intervention for children. This could be applied universally, and we want to prevent the uptake of commercial tobacco use, so they don't start smoking cigarettes. That is the primary goal. But then going down the list here for secondary prevention, it might be something like cessation help for folks who are already smokers. They may have engaged in the behavior, they may have already developed the habit or the dependence, but we want to get them to stop before it gets any worse, before the smoking leads to disease or death. And this approach probably most most easily would translate to, as I said, smoking cessation interventions for the folks who are already smoking cigarettes. But then moving down further to tertiary prevention, in that spirit of minimizing the damage from the problem that has already occurred, it could be reducing the effects of the cigarette smoking on other people who are not yet smokers. This could be something like environmental approaches to reduce secondhand smoke. There are oftentimes attempts to designate smoke-free buildings, housing, maybe even households adopt rules about smoking outdoors, not inside. And this is in the spirit of that tertiary prevention, minimizing the damage from a problem that is already occurring. Alongside this notion of levels of prevention, there's a little bit newer idea that I'm showing on the screen here, this notion of a health impact pyramid. This actually was proposed almost 10 years ago by Thomas Frieden, who was at the time director of the Centers for Disease Control and Prevention. And what he said is that there is a balance between the burden that we put on individuals and the benefit to the population at large. And he's not necessarily recommending one part or one aspect over another. He's really calling us to pay attention to where we are putting our efforts, where we're working at. Very often, our automatic response, and certainly in the general public, the automatic response is to think about educating the people who are smoking or educating the people who are engaging in the problem, doing something very intensive and very personal with a very small segment of the population. That is represented by the peak of the pyramid here, the triangle at the top that is labeled counseling and education. What that means in this framework is that there is a high burden or high demand put on individuals that actually doesn't have a whole lot of population or community benefit. It has substantial benefit for the individual, but you have to do a whole lot of work with a whole lot of individuals to get much of an impact at the community or population level. As you work down towards the base of the pyramid that's shown on the screen here, you get into areas that are maybe a little bit further removed from the immediate problem and a little bit further removed from the individuals to start taking more of a community or population perspective. And in these cases, when you are starting to work down towards the bottom of the pyramid, you tend to see much more community benefits, but with less individual impact or individual burden. The example that I give a lot of times from my alcohol-related work is that if we could get everybody in Iowa, since this is where I'm at, to drink maybe one drink less per month, that would be a very small change in individual behavior. But when we aggregate that over the whole state at large, that could be a pretty substantial reduction in the amount of alcohol consumed. That's the notion of the trade-off here of more population benefit with less individual burden. The other thing to think about with this is that when we are focusing more on individuals, we're taking more targeted approaches, more individualized, and that as we work down towards lower levels here of this pyramid, it's oftentimes much more universal approaches. So focusing on the environment, the context, the socioeconomic factors that all these individuals find themselves within. In the case of tobacco control, our example of that tertiary level of restricting where people are smoking to avoid exposure to secondhand smoke, that would be a great example of working at the lower levels of this health impact pyramid. Great population benefit. We're focusing on something about the context or characteristics here, not as much individual burden, and that's the ratio or the payoff. So I'm going to wrap up here with my first recommendation about the framework is that it really pays to begin any sort of tobacco prevention work by thinking this through carefully by focusing the project on a particular level of prevention, or maybe if you want to use that health impact period, what level of that pyramid you'd want to work at. This is some of that very preliminary work that I'd recommend before starting to do anything else. The second thing that I wanted to talk about in terms of this framework is assessing community readiness and community engagement. Here at the University of Iowa in our College of Public Health, this is one of our emphasis areas. We really focus a lot on community engagement. And I think that's a hallmark of really successful programs, getting the whole community on board, to get the buy-in, to get the, whether they're the key leaders that you need to move forward, or just having community consensus that this is a health problem that we are ready to tackle. It really increases the effectiveness of anything that you're going to do. As you can see on the screen here, I've got a couple of summary bullet points here that oftentimes we look at this as a necessary condition for making any sustained change. If we want to have a lasting long-term impact, this is really going to be a requirement so that whatever we do with our intervention or our health campaign doesn't evaporate once the campaign is over. Having the community involved also has the advantage that oftentimes they will tell you exactly what needs to be done to tailor the activities, to make it best fitting, to make it most appropriate for the committee or the community that you are working in. This is especially helpful when you're dealing with anything that may be culturally sensitive, or where you're adapting anything for a particular cultural context. We know that things that work in one place are not necessarily guaranteed to work in another without thinking through some of these things about fit, acceptability, cultural appropriateness. One of the challenges about this, however, is how we're going to define community. And there are a number of ways that people go about it. In fact, 3 ways primarily. One could be geographically, that we define community by the boundaries of a town or a county, a school district. There are essentially administrative lines that are drawn that we could count that as community. The drawback of that is that sometimes it maps on with an identity and sometimes it doesn't. People don't think of maybe their county as their unit of identity. It's more their neighborhood, or there may be some other more meaningful, more relevant aspect. So we need to find out what is the meaningful identity, what is the meaningful sense of community. A couple of other ways that oftentimes community is defined, however, is by either demographic characteristics or functional characteristics. So demographic characteristics may be, say, a racial ethnic group, the Black residents of Iowa City, for example, a group that they may or may not see themselves as a cohesive identity or community, but we can define them as a distinct subgroup for our purposes. Alternately, as I said, there may be functional definitions, things like bus riders, or in our case here, cigarette smokers. We may be defining the group by their behavior. What I recommend, again, as a preliminary step to assessing community engagement and their readiness in any tobacco control efforts, is to actually do some assessments of this community readiness. On the screen, you see just a screen grab from another website, and I've linked the URL or put the URL down below. SAMHSA, the Substance Abuse and Mental Health Services Administration, has a really nice resource set of resources on their website for community readiness assessments. There are, I believe, 5 or so different tools there that community groups could use. And these are primarily things like either questionnaires, checklists, or guides to the questions that you should be asking to assess readiness. On the screen here, you'll see it does include some details here about who you're going to be asking, whether it's community members at large or maybe just the key leaders in a community. And it doesn't define it any more than that, because this is really essential about the tailoring to each context, that who the leaders are may vary, and that's part of the preliminary work, is to figure out who are the leaders that you would need to talk to, whether they're in formal positions or maybe informally, they just serve as an important person, a resource, somebody that people look to for information, for guidance, for informal sort of leadership. And the example you see on the screen here, the first one is a 48 question questionnaire to be asked of key leaders. Oftentimes with these resources, there are scoring instructions, so that it's not just the questions to ask, but how are you going to interpret the answers that you get back, and then how do you determine the level of readiness. I mention this because I think this is essential. If a community is not ready to address tobacco, whatever you're trying to do is probably not going to be successful until you get everybody on board seeing tobacco use as a problem. Either the community just may not recognize it, they may not be prepared because they have competing needs, or there's another issue that is more important that the community is not maybe deciding to address tobacco use. You need to figure out where the community is at before you can launch any sort of prevention campaign. I'd encourage folks to take some time to look at the SAMHSA website. I'm not going to bring up any of the examples of the resources, the guidelines, the questionnaires that they have there, but it is definitely something worth poking around and looking around. Not every questionnaire or community readiness assessment is necessarily going to be suitable for each community too. So it's going to take a little bit of time to figure out which one is going to work in your particular context. But this is a great starting point for those basic resources. Then we come to my second recommendation here. Before beginning any prevention project, assess the community's readiness to engage in tobacco work. So the next part of this, say that we have assessed our readiness, the community is ready to address tobacco, it is recognized as a health issue. How exactly are you going to address it? And here we can lean on this resource of evidence-based interventions, or sometimes they're called EBIs for short, because that's a bit of a mouthful. This has gotten a lot more attention in public health of late, this whole notion of evidence-based public health. So I want to explain just a little bit about what that is, talk a little bit about the advantages or the rationale why it's getting so much more attention, and then talk about where to find some of these interventions and how to assess and adapt them to your own community. So in the most basic sense, an evidence-based intervention is a program or a policy or an activity that's been rigorously developed and tested or evaluated scientifically. Most times when we talk about rigorously developed, we mean that it is based on some sort of behavioral theory, or there's some sort of theoretical underpinning. It's also developed by specialists who are aware of the empirical literature, the research literature that goes behind it, so they know that they are using the best available science. And then it's also been tested. It's not just a good idea that has been developed, but it's actually been put through its paces, tested out in the world to see that it does work as intended. In shorthand, you could think of this as programs or policies or activities that have received some sort of seal of approval. They get that check of approval here. The reasons that evidence-based public health has gotten increasing attention over the last several years is that it's sort of the ideal combination of science that increases our confidence in being able to achieve whatever we set out to achieve. If we have an intervention that is evidence-based, that is about reducing smoking levels, we can be more confident that using that intervention is actually going to get us our outcome that we want. There are other advantages that go along with that, like avoiding duplication of efforts. If somebody has developed a rigorous and well-tested and scientifically sound program, we don't need to go through the effort of starting from scratch and developing a new one. We could look to what's already out there, what people have already developed, and then we focus our efforts on deciding whether we can use it in our communities, and if so, how much we might need to adapt it. So it can be much more efficient to look at these EBIs that are already developed. It also is possible to make a stronger case for using your resources if you're using an evidence-based intervention, saying, I have higher confidence in getting my desired outcome. It's already been developed, so I'm going to be maybe saving the development effort. I can focus more on the implementation or adaptation. So it can be a good justification for resources. The flip side of that is that increasingly I see that this is actually required by funders. So the philanthropies, the agencies, maybe the federal government, some of the different parts are increasingly starting to require that the folks that they fund for their local work use an evidence-based intervention. And then the last point here, and this is something that I find very important being in academia, is that it really bridges the academic and the practice worlds. Too often we are stuck in our ivory towers doing our scientific work with insufficient contact with the folks out in the real world that are the intended beneficiaries or the folks that are going to be using our programs. Just as much as our interventions need to be grounded in good science, we also need them to have good practice or have that feedback from the practice side. And when we use evidence-based interventions, we oftentimes have much more contact back and forth between the developers and the users of their interventions, so that the folks who started the EBI, developed the intervention, actually get more knowledge, more feedback from the real world users, and that in turn can help improve their science going forward. Okay, so let's get down to a couple of nuts and bolts about using EBIs. First question, of course, is where do I find these interventions that have already been developed? And nowadays, there are great resources online. You can just search for them in Google or whatever search engine. A lot of times different agencies will have directories established. I'm going to point you to one in particular that I think is quite good. A lot of these online directories are detailed enough that you can sort by things like topic, so searching for tobacco interventions, or maybe searching by population, adolescents or youth or adults, by setting, say rural or urban areas, and so on. So you can do a much more tailored searching here. In a number of these online resources, you can actually find the materials or details of how to find the materials, and especially some key details like whether there's a cost to use the intervention or whether it's freely available. Maybe there's some background information there. You can find out how it's been evaluated, how many other people have used it, and look at maybe their experiences or their reports of it. Let's see, I think I covered those other couple of bullets there in these online resources. Yep. So the one source that I'm going to recommend as a starting point, it's not the only one, but it's really a well-regarded and pretty comprehensive resource, is a website called the Community Guide. It's managed by the Centers for Disease Control and Prevention, and on the screen I just have a screenshot of the web page. This is the starting page. Uh, and I typically recommend to folks to start here when they're looking for an evidence-based intervention or when they're just looking to explore a particular topic, because there's a whole lot of information that has already been summarized here. In this case, for example, if I wanted to look for, say, youth tobacco prevention programs, or I guess not just youth, on the screen here, my example, I typed in tobacco prevention programs in the search bar. And then down below on the screen, you see an example of the results that will come back. And there are hundreds of results that come back here. It does take a little time, depending on the topic, to really look through everything and understand what has come back. But this is probably the best starting point, the most comprehensive source for all that we know about tobacco prevention programs here. I'm not going to necessarily click through all the levels here, but if I were to, it's just a couple of steps away from coming up, from pulling up a page and a form here that is a summary of comprehensive tobacco control programs, summarizing specific strategies and the evidence behind them. And this is a good starting point for figuring out what you might be able to implement in your community, given that you know what level you're going to target for prevention, that primary, secondary, or tertiary, given that you've established your community is ready to tackle tobacco use. Then you can review the different strategies and see what looks appealing, what may fit, what is promising. Now I'm going to stop here for a second and give a big caveat. For all that I talk up the community guide, and I do think it's a really great resource, there are some important limitations. To my knowledge, there is no program yet listed in the community guide specifically for American Indian communities. This is a real shortcoming here. What that means is that you could either look to other sources for specific programs that have been developed in American Indian communities, or look to some of these programs that have been developed elsewhere and have to go through the process of assessing fit with your particular community or the American Indian community. Some of the resources that you may already be aware of, but I can point you to in terms of looking at what other American Indian communities have done, are these three on the screen right now: Clearway, Minnesota, the National Native Network, and then even Indian Health Service. Each one of these websites has a summary, essentially a shorter directory of different tobacco control programs that have already been developed and implemented in American Indian communities. This may take time to research, to find the programs, to get the details, and to assess the fit. For all of this, I'm not going to promise any quick fixes. It really does need time to go through and understand what the EBI is, how much evidence is behind it, how strongly it may be recommended or not. And in fact, I'll jump back to the community guide for a moment. One of the features of the community guide is they will give you a evaluation of the evidence. You'll get either a recommendation that there is good evidence behind it, it's scientifically developed, rigorously evaluated, it's a good product, it has good indications that you'll get the results you want, so it may be a recommended. You may also see things that get a label of not recommended, that despite good approaches, despite the scientific grounding, for whatever reason, things may not have worked as intended, or sometimes there may be adverse effects, things that we didn't realize might happen, but we don't want to inadvertently cause any harms. We don't want these sort of secondary effects that might not be good. So they have a label, a category of not recommended. So it's important to pay attention to that as well and avoid those. And then there's also a middle category of insufficient evidence. And a lot of times we see this with things that are fairly new, that there hasn't been a whole lot of work yet. Maybe there is an area that hasn't been explored. Maybe there haven't been a lot of interventions done. Or maybe an intervention has been developed, but it hasn't been implemented in other places yet. So we don't yet have a good body of evaluation information. So those may be useful, but I would be a critical consumer, would know that there is insufficient evidence to say it doesn't yet have that highest ranking of being a recommended program, but it may be promising. It may simply need more evaluation or more work. Okay. So as I mentioned a couple of times, well, actually, my recommendation here, sorry, my third recommendation is that you look for EBIs online in these different resource directories and search multiple resource directories to make sure that you know the full range of what might be out there for whatever you are intending to do for your prevention project. The next step, given that you may have identified an evidence-based intervention that fits the target of your work, is to assess how well it's going to fit in your community, assessing and adapting it. The idea here is that, as I mentioned before, something that was developed in a different community is not necessarily guaranteed to work in yours, even with the best rigorous evidence behind it. Because we know that the context can vary, and the way that we go about fitting it to our communities is typically by adding or deleting or substituting or changing some parts of it. But we have to be careful about that, and there are some steps to take in figuring out what is safe to add or delete or substitute. My caution here is that we need to strike a balance between the original formulation, because that was the one that worked, the way that the EBI was originally developed, keeping that integrity and balancing that with any changes that we need to make to fit into our community. I would like to recommend this 5-step process from the Cancer Prevention and Control Research Network, or CPCRN. You can find these details and a little bit more explanation online if you'd like to search that, but I'm going to give you a quick overview of this as a model to approach assessing and adapting interventions. And as you see on the screen, the 5 steps are: first, deciding how well the EBI fits your community or not, and then determining whether you need to adapt it, how important it is adapting these certain elements if there is a difference from your community, deciding how to adapt it, actually making the change, and then doing some tests of the change to see how it works. I'll go through some of the examples here in just a moment. I like this framework from the CPCRN because they give you essentially a template or a guide of the things to work through here. And this is actually a sheet that you can download and use as a sort of worksheet here, the one that you see on the screen here. What you would do when you're first assessing your fit is start on the left-hand side with the first 3 columns. And it gives you a few different categories here: the rows of the table, the health outcome that you're focused on, the behavior that may be related to it, aspects of the environment, the determinants and methods, what's underlying or what's causing the problem or the behavior, aspects of how you might want to deliver it, either how the intervention has been delivered or the way that you want to deliver it. And then the columns here, in the second column, sorry, that's labeled your community, here is where you would write down or describe the characteristics in your community that either exist or that you want to change. So for example, in maybe a youth tobacco prevention campaign, something that's primary prevention focusing on the subset, stopping young folk from picking up cigarettes in the beginning, you could list that as your goal. Preventing, children and adolescents from starting smoking. Then what you would do in the third column over, the one that says EBA, evidence-based activity, you would describe or write out those same details, but for the intervention that you're considering. So maybe what you found that looks the best, that's most promising, is tobacco prevention for college students. So you would write that down in the details that the intervention has a slightly different population. And then as you move across to consider potential adaptations here, the middle columns are where you would start to flesh out where it lines up between what you want to do and what the intervention has been designed, and the degree to which you might have to change something, changing either activities or materials or some other sort of aspect of the intervention. Here, as you work across the worksheet, I actually like to write out a description of the challenges or the problems, or conversely, the ways that it aligns. If they're in agreement, you can write out, these align, these are in agreement, they focus on the same goal or the same behavior, or conversely, make a note of how they're different. The middle set of columns that are labeled red and yellow and green, this is where you have to do a bit of judgment. This is where maybe the art meets the science of all of this, where you have to assess what is possible to change without impacting the intervention's design, where you may have to tread a little more cautiously or be more careful, the yellow column, the maybe, and then there are clearly some areas that you cannot change because it's fundamentally going to weaken the intervention. The question, of course, is how do you figure out what are the things in these different categories? What's the red or the yellow or the green, the things to avoid versus the things that you can likely adapt? The green column, the most easily adaptable, are things that are going to reflect your local community. So changing images, pictures that are used in any materials, using local information, say the statistics about smoking prevalence in your community, customizing it to that local context. Those are things that are almost always completely safe to adapt, and that will actually be beneficial, increasing maybe the acceptability of the intervention, because folks can see that, oh, this is reflective of my local experience or my local context. The middle category of the yellow, which is the area where we urge caution, it's likely okay that you can make some of these changes, but you just have to think through it carefully and be attentive. It could be things like changing the order or the sequence of activities in an intervention, maybe going from one population to another. As I mentioned earlier, maybe you found prevention intervention for adults, but you want to use it for adolescents. That is probably okay, but you have to approach it with some caution and think through the details carefully. The red category on the left side of the screen are the things that are really essential, that you don't want to change or edit or revise in any way. The fundamental mechanism that is driving the change, the behavior change, or the behavior topic. So, for example, if you found a great intervention for preventing binge drinking, you would not attempt to adapt that to preventing smoking. Those are you just don't switch topics, you don't transfer topics. That just isn't done. Some of the other things that you would want to avoid are things that would weaken it, like reducing the dose or removing sets of activities or components of the intervention. As I said before, in the yellow category, something like reordering or resequencing, changing when you do particular activities, that may be okay if you think through that carefully, but it is likely not okay to remove a whole set of activities from your intervention, to drop a component, maybe to eliminate a module from something. that would be a more serious change that we recommend against. How do you determine this red zone? This is, like I said before, where the judgment, where the art meets the science. It really is beneficial to use a team approach here. No single person can decide what is safe to adapt or what is off limits. Some of the typical resources that I recommend to folks is to look to colleagues that may have gone through this process. If there's anybody that has adapted an EBI for their community, you could reach out to them and find out what their experience was like, any lessons that they learned. Oftentimes, funding agencies will provide technical assistance, or they'll have at least scientific officers who may be a resource for you. But also in that vein of technical assistance, the Prevention Technology Transfer Center here can offer that. You can also reach out to just other academics or researchers, sometimes even the originators of an EBI, the folks who developed it in the first place, to ask for help, at least determining what's essential and what may be open to adaptation or change for your community. Then the final step in working our way across the table here, across this sheet, is to come to the final column here to make that decision. Are you going to make the change or not? Sometimes this decision is driven by where the change falls in that yellow, red, or green categorization. The final decision could be no, you're not making the change if it is something that relates to that essential component. You may also find out once you get to this point, and as you look at the changes that are necessary and whether you can make any adaptations, whether that is actually the right evidence-based intervention for you. You may go back to that initial step of searching for evidence-based interventions. You may end up this process by determining that, well, this looked promising, but it's actually not going to work because some of the changes that would need to be made are part of those essential things that I cannot touch. Conversely, you may find that, okay, there are only a few areas that I need to adapt. I can do that. I can strategize how to make that change and move forward with this. I've found the evidence-based program that I'm going to use. The guidance on getting that decision for the final column I was going to mention is, again, consulting with all of the experts, including your community members, about things like the reach. Is this going to be available? Is it going to be acceptable? Can it feasibly be done within your context? Then making the adaptation, of course, you're not going to consider anything that fell into that red category, so only the simpler, more straightforward adaptations that would be under this green category, or some of the things that may be a little more complicated, but you can approach with some caution and can do successfully. The last stage of this is to do some preliminary testing to make sure that your changes are going to work as intended. And there are two broad ways that you might approach this. If you've changed things like materials, say a brochure, you want to test to make sure that folks can read the brochure, that they understand it as intended. You may do some assessments like gauging how long it takes for folks to maybe read the materials or get through it. You could also try using it on a very limited scale. Say, for example, if you did something in a medical center, you want to make sure that your intervention fits in with the flow of the clinic, that it doesn't disrupt activities, that it doesn't overburden some of the personnel. Say, for example, if you're relying on nursing staff to implement parts of it, that they realistically can do that in addition to their other job duties. This is really part of the best practice of making sure that your adaptations are going to work as intended. So I'm going to say as my final recommendation here, the fourth one is to use this framework, this table, this guideline to assessing potential adaptations as described by CPCRN. The website is on the screen here, so you can follow up with more detailed information. You can also reach out to either the PTTC or any of the other resources that I mentioned for additional guidance or feedback on approaches. just going to end with a couple of other resources, and I realize we're closing in on the end of the hour, so we'll have a little bit of time for questions or discussion. I'm going to recommend one additional resource coming from the University of Iowa here. We have a prevention research center for rural health, and this may not necessarily have a focus on American Indian communities, but one of the resources that we do have here, if you go on the website and look under tools here, it'll bring up a drop-down menu, and towards the bottom and the resources, you'll find a webinar that we have recorded on this process of finding and adapting evidence-based interventions. It goes into more detail than I was able to go into here today, but it's the same sort of resources if you want to know a little bit more detail about what this CPCRN framework for adaptations is exactly. I'm going to put in a final plug for the PTTC and the ATTC as resources for technical assistance with any of this. And then let me just summarize here with the 3 recommendations that I had. To start your prevention work by determining the level that you want your activity to be situated at. To assess your community's readiness to tackle tobacco prevention. And then to look to programs and policies and activities that have already been developed because they're more, it's more cost effective, it's more efficient, and to focus your attention really on adapting these existing EBIs for your local community. All throughout this, though, I'll caution that this does take time at each one of these steps, and to make sure to allow for that. So with that, that is the end of my slides and my formal presentation, and I'm happy to discuss anything or field any questions that you might have.
I think Cindy was trying to unmute herself, but I'll just jump in and remind people that they can chat their questions in the chat box, which is just next to the presentation, and looks like some people are mentioning some other resources, so thanks for those comments. And while we're waiting for any questions to come in, I'll just remind people that we will be sending a follow-up email to everybody who attended and everyone who registered, actually. So you'll get an email with the recording link to today's presentation, as well as handouts of the slides, and also the link to the GIPR evaluation will be included there in case you don't get linked to that when we finish up here. But yeah, we would welcome your feedback. We would love to hear what people think about today's presentation. My apologies.
Even be aware of.
Sorry about that.
Oh.
Paul, I just lost the connection there, so I don't know if people were hearing anything, but I'll let you keep going.
Sure, yeah, I'm sorry. I noticed it looked like I cut out or somehow we got disconnected, but it looks like we're connected here. One of the questions here is to comment on the vaping issue. Boy, oh boy, that is a big topic, and I'll see if I can summarize it. The current debate, I guess, is whether this could be a harm reduction approach, so getting folks off of combustible tobacco, cigarettes, as a less harmful strategy, or whether it increases the risk of tobacco use, whether it's sort of that stepping stone or gateway. From what I understand, the literature is pretty young and evolving. It seems to have different effects for different groups. Among adolescents, which is the adolescents and young adults, the group that is taking up e-cigarettes and vaping at the greatest rate, there is some concern that this may be introducing nicotine dependence that actually leads to combustible cigarettes, while the converse seems to be happening in adults, in established smokers, that this may be a way to get off of combustible tobacco and actually a step towards quitting, not necessarily addressing the nicotine dependence, but at least maybe a step towards that harm reduction. I don't think we have a very clear consensus yet, at least in the public health community, about whether we recommend it or not, or where we stand on it. That's probably about the best I can say about vaping right now.
Well, it looks like there are still a couple of comments are coming in, and just want to thank everyone for participating and for your involvement. And sorry about that lost connection there for a minute, but again, just want to thank you for joining us, and I want to thank Dr. Gilbert for presenting on this project for us, um, and yeah, we hope to have you back again to discuss more about this process of prevention programs. And yeah, again, thank you everyone for being here today, and we will be getting in touch again on with the follow-up emails that we mentioned. And also just be aware that we also have a mental health webinar coming next week, Wednesday. So watch for that as well. And Dr. Gilbert, is there anything else you wanted to say before we finish up?
Nothing else. There was just one last comment here. As another resource for the vaping issue, the Massachusetts Bureau of Addiction Services has it sounds like a curriculum, life skills, I think, with anti-vaping strategies. I wasn't familiar with that, so thank you for the suggestion.
Wonderful. Well, thank you so much, and thanks for sharing those resources. So I hope people were watching the chats, and there's a lot of helpful things there. So thank you for sharing those. And again, thanks for joining us. We hope you all join us again next time.